And so we move to another chapter devoted to leg ulcers. I'm going to read you several vignettes of some very characteristic types of leg ulcer. A 67-year-old diabetic has an indolent, unhealing ulcer at the heel of the foot. Now, you're not surprised that a diabetic would have a foot ulcer, but you know this is due to diabetes because of where it is. You see, the problem in the diabetic is he doesn't feel the pain. The neuropathy prevents him from recognizing that there is an area of injury to his foot. And so we see these primarily at a pressure point, the heel or the head of the first metatarsal. You then work up the patient, you find out that he's diabetic, and if you control the diabetes and keep that ulcer clean and keep that leg, horizontal in bed with the patient off his feet, it, at least theoretically, will go on to heal. The sad reality is that most diabetics, once they get an ulcer on the foot, may end up with an amputation. But the USMLE wants you to do the best for the patient, so the answer you pick is control the diabetes, keep the ulcer clean, keep the leg elevated, keep him off his feet as the best way to treat him. Now, vignette 68 says a 67-year-old smoker with high cholesterol and coronary disease has an indolent, unhealing ulcer at the tip of his toe. The toe is blue. He has no peripheral pulses in that extremity. That suggests arteriosclerotic occlusive disease. The patient has all the characteristics, and the ulcer does too. Because when a foot ulcer is due to arteriosclerotic occlusive disease, it's typically as far away from the heart as you can be at the tip of the toe. You start the workup here by doing Doppler studies, looking for a pressure gradient. This is sometimes expressed too as an ankle brachial index. If there is no pressure gradient, the problem is in the small vessels. Do not do an arteriogram because it will be normal, and don't think of a surgical intervention because it will not help. But if you identify the pressure gradient with a Doppler study, then you follow with the arteriogram and eventually with revascularization that may enable then the ulcer to heal. And we'll have more to say about this on the chapter on peripheral vascular disease. Now, vignette 69 refers to another type of chronic leg ulcer. A 44-year-old obese woman has an indolent, unhealing ulcer above her right medial malleolus. The skin around it is thick and hyperpigmented. She has frequent episodes of cellulitis and has varicose veins. That's a venous stasis ulcer. It's unmistakable. It's always in the same location, above the medial malleolus, in an area of skin that is indurated, hyperpigmented. The management starts with external support. Elastic stockings, support stockings, ACE bandages, Una boot, which is a contraption where you have sort of like the equivalent of an elastic bandage impregnated in a resin that sort of sets almost like a cast. And in advanced cases, you may need to do surgery, varicose vein stripping and ligation of the collaterals and perhaps skin graft. And the next two, vignette 70 and 71, represent another type of ulcer in the lower extremity that doesn't heal, that actually has a very different meaning. These are not terribly common, but they need to be recognized. This could lead to the death of the patient. A 40-year-old man has had a chronic draining sinus in his lower leg since he had an episode of osteomyelitis at age 12. In the last few months, he has developed an indolent, dirty-looking ulcer at the site with heaped-up tissue growth at the edges. Let me read vignette 71 because you're going to recognize a common theme between the two. Ever since she had an untreated third-degree burn to her lower leg at the age of 14, a 38-year-old immigrant from Latin America has had shallow ulcerations at the scar site that heal and break down all the time. In the last few months, she's developed an indolent, dirty-looking ulcer at the site with heaped-up tissue growth around the edges, which is steadily growing and shows no signs of healing. You recognize both of these have had a sequence of an ulcer develops on the foot, it heals, it then breaks down again, it then heals again, it then breaks down again. And this is happening for 20 years. Eventually, a squamous cell carcinoma develops there. That is that heaped up tissue growth around the edge. We even have a name for this kind of an ulcer, which is in fact a squamous cell carcinoma. It's called marginal ulcer. So what you need to do for this one is to biopsy that edge of the ulcer. The pathologist will recognize squamous cell carcinoma. We need to resect the area, do skin graft, perhaps look after lymph nodes if they might be involved. And we move to a brief review of foot pain. Let me repeat this. In fact, I'm going to show you sort of a little table on the screen so we remind ourselves again of the different types of foot ulcers. If the ulcer is at the tip of the toe, you think of arteriosclerotic occlusive disease. If it is at a pressure point, you think of diabetes. If it is above the medial malleolus, with the skin surrounding being hyperpigmented, you think of venous stasis. And if it develops after many years of repeated breaking down and healing process, you think of squamous cell carcinoma. And now we're going to have a little chapter, only 3 vignettes, devoted to foot pain, which incidentally will be the end of the orthopedic review. Vignette 72. An older, overweight man complains of disabling, sharp heel pain every time his foot strikes the ground. The pain is worse in the mornings, preventing him from putting any weight on the heel. X-rays show a bony spur matching the location of his pain. And physical examination shows exquisite tenderness right over that heel spur. You will not be surprised to know that for many years, what we did for these patients was surgically remove that little piece of bone. It seemed to be the reason for the problem. In fact, it was the consequence of a problem, not the genesis of a problem. What this patient has is plantar fasciitis. Very common but poorly understood problem that needs symptomatic treatment until it resolves spontaneously within 12 to 18 months. So this patient doesn't need a surgical intervention. Vignette number 73, a woman who wears high heels, pointed shoes, complains of pain in the forefoot after prolonged standing or walking. Physical examination shows a very tender spot in the third interspace between the third and the fourth toes. This is a Morton neuroma, an inflammation of the common digital nerve. If conservative management, including the wearing of more sensible shoes, does not suffice, the neuroma can actually be excised. And before we all blame women for wearing those pointed shoes, this could happen to the men who wear the cowboy Texas boots that are pointed. So this can happen to any gender. And vignette number 74, a 55-year-old obese man suddenly develops swelling, redness, and exquisite pain at the first metatarsophalangeal joint. This is gout. You diagnose the acute attack with the identification of uric acid crystals in fluid from the joint. The treatment of the acute attack relies on indomethacin and colchicine, and long-term control of serum uric acid levels is done with allopurinol and probenecid. And you're looking at a picture now, that classical gout, that red, angry-looking toe. Let's look again at some of these pictures because they are so characteristic. The first one you're looking at, which we have already seen before, is a diabetic ulcer with dry gangrene. The location alone makes the diagnosis so easy for you. This is at a pressure point, just where you expect a diabetic ulcer to be. And this is a picture of the way the venous stasis affects the lower leg. And you see the swelling, edematous, hyperpigmented area where typically ulcers might develop above the medial malleolus. And finally, we had already talked about this as well. This is a classical picture of gout. You can look at the toe and see the red inflamed joint. You can see the crystals of uric acid that are drawn from the fluid and looked at the microscope, and this is how you make the diagnosis during the acute attack, and this is the way that would look on an X-ray. And this is the end of the orthopedic vignettes.